The financial cost of addiction is staggering. It is estimated that in the United States the costs associated with substance abuse are estimated at over $740 billion annual. This significant financial loss does not account for the stress, grief, and suffering endured by families and friends as a result of addiction. The purpose of this concept presentation is to develop a generalist nurse conceptual paradigm for the recognition and assessment of addiction on individual, family, and community levels. A conceptual understanding of addiction will enable nurses to analyze patient data for the planning and implementation of interventions necessary to ensure patient safety during emergency management and to motivate patients towards successful recovery from addiction during non-emergency management. Definition. Terminology related to the concept of addiction is controversial and subject to debate. For the purpose of this concept presentation, the term addiction is defined as a compulsive, abnormal dependence on a substance or on a behavior. The dependence typically has adverse psychological, physical, economic, social, or legal ramifications. 2. The American Psychiatric Association defines a wide range of mental disorders in the Diagnostic and Statistical Manual of Mental Disorders. The terms substance-induced disorders and substance use disorders are used as diagnostic. Category 3 Substance-induced disorders involve the direct effects of the substance, and substance use disorders include cognitive, behavioral, and physiological symptoms associated with long-term use. 4. These distinctions are clarified further in the sections that follow. The term intoxication is used to describe behavioral and/or physical symptoms that result from substance use. Craving in the context of this concept is used to describe a desire to use a substance and is a symptom associated with substance use disorder. Tolerance, another symptom indicating substance use disorder, is defined as an increasing need for the substance to achieve its reward. A lack of reward from the same dose as previously taken would also be considered tolerance. Withdrawal refers to a syndrome of symptoms that occurs from a sudden cessation of taking the substance. 3. Scope. This concept presentation examines addiction from the perspective of two broad categories, the substance addictions and the behavioral addictions. There is some controversy regarding whether behavioral addictions exist, but as new developments occur in understanding brain neurochemistry, it is becoming more evident that substance addictions and behavioral addictions are the result of similar neurochemical process for normal physiological process. Unlike most concepts presented in this book, the concept of addiction does not have a normal physiological process because addiction is never considered normal. However, there is an expected physiological process associated with addiction. Discussions of addiction physiology focus either on the exogenous signs and symptoms of substance abuse or on the endogenous neurochemistry underlying these signs and symptoms. The neurochemical relationship between addictive behaviors or substances and various neurotransmitters in the brain depends on complex models now being explored on the frontiers of addiction science. 5. It is believed that neurochemical interactions related to addiction originate in the caudate nucleus, the nucleus accumbens, and the ventral tegmental areas of the brain, otherwise known as the reward centers. The reward centers are affected in different ways depending on which neurotransmitters and other brain areas are involved in various reward pathways. It is evident that the neurotransmitter dopamine plays a key role in many or all addictive processes, whether chemical addiction 5 or behavioral addiction 4. Dopamine is directly associated with the euphoric reward known as being high, and other neurotransmitters are associated with dopamine regulation. Examples of other neurotransmitters identified as involved in reward pathways include the endogenous opioids gamma-aminobutyric acid, glutamate, acetylcholine, norepinephrine, and serotonin. Variations and context. As mentioned previously, the scope of this concept is represented by two broad categories, substance addictions and behavioral addictions. Substance addictions. There are two major categories of problems stemming from substance addictions, substance-induced and substance use disorders. Substance-induced disorders. Substance-induced disorders are temporary and reversible, caused by the immediate use of a substance and the immediate effect that occurs when the substance use is discontinued. The substance affects the central nervous system, causing physiological, psychological, and/or behavioral effects. The symptoms of intoxication or withdrawal are related to the specific substance or substances used. Thus, these disorders can include not only the intoxication/withdrawal but also other conditions associated with intoxication and withdrawal, such as depression, anxiety, or psychosis. 5. Figure 351 Scope of addiction. Substance use disorders. Substance use disorders result from continued, frequent use of a substance. The consequences occur over time as a cumulative effect as the addiction progresses. Substance use disorder combines abuse and dependence into a single diagnostic category with mild, moderate, and severe subclassifications. Although each substance is its own disorder, the same overarching criteria for diagnostic purposes are used. According to the DSM-5, meeting 2 of 11 criteria within a 12-month period is indicative of substance use disorder. The severity is based on the number of criteria met. 3. Behavioral addictions. Although less clearly defined, there are many examples of behavioral addictions found in the literature. Like substance addictions, there are several behaviors that produce a reward response similar to the neurochemical processes previously described. An alternative perspective is that behavioral addictions actually represent impulse control disorders. This perspective has given rise to significant debate regarding the legitimacy of formally recognizing behavioral addictions. Although only one behavioral addiction was included in the DSM-5 diagnostic criteria, 3, a less restrictive view is used for this concept presentation. Other behavioral addictions found in the literature are included. Consequences. Depending on the individual and the particular addiction, the consequences of addiction are highly variable. However, an understanding of particular neurochemical processes known as habituation and adaptation forms a conceptual foundation for understanding all addictions. Habituation begins when neurons that receive a repetitive stimulus chemically inhibit their own receptors to restrict the stimulus. Habituation permits the organism to tolerate primal suffering such as hunger, pain during a famine, but habituation also facilitates higher-order functioning. For example, as a result of habituation, city dwellers are able to sleep in the presence of city sounds such as traffic noise or sirens. If a repetitive stimulus persists, the neurons will permanently restrict a sufficient number of their own receptors to permit functioning of the organism in the presence of the stimulus. This is called adaptation. In evolutionary terms, adaptation began as a survival mechanism allowing the organism to establish a new equilibrium in the presence of an unceasing, long-term stimulus. Once adaptation to a repetitive stimulus occurs, the stimulus must be increased to overcome the adaptation for there to be perception of the same stimulus. A user of cocaine who has adapted to a particular dose, for example, will no longer perceive a high on the same dose, therefore the dose of cocaine must be increased to get high. In turn, the brain neurochemically adapts to the increasing doses of cocaine in an addictive cycle known as tolerance. That is, habituation and adaptation cause tolerance. Any behavioral reward, such as pleasure, is in fact a neurochemical process mediated by neurotransmitters. Therefore, the brain will habituate and adapt neurochemically to repetitive behaviors such as gambling in the same way as it will adapt to ingested substances such as cocaine. Gamblers have to gamble more often for higher stakes to overcome the brain's adaptation to the gambling high. All the neurochemical consequences of substance use, whether alcohol, tobacco, cocaine, amphetamines, opiates, or others, apply to non-substance addictions such as money, power, relationships, sex, pornography, computer games, television, work, exercise, sports, and even addictive thought patterns such as worry or rumination. 4. The processes of habituation, adaptation, tolerance, and withdrawal are well illustrated by an individual who is too anxious to sleep. The anxiety triggers the release of adrenaline as part of the fight-or-flight response, and insomnia results from the adrenaline. The brain recognizes the importance of sleep and will eventually block the anxiety stimulus so that sleep will occur. Some motor vehicle drivers have experienced this mechanism. The brain chemically overwhelms the alertness necessary to stay awake, and accidents occur when drivers fall asleep at the wheel. Tolerance and withdrawal enter the picture if a sedative is taken to artificially overwhelm the stimulus of anxiety to achieve sleep. In this case, instead of blocking the anxiety stimulus, the brain will block the sedative by signaling the release of more adrenaline. The need for increasing doses of the sedative to overcome the increasing level of adrenaline is tolerance. If the sedative is abruptly discontinued, the brain does not immediately stop signaling the release of adrenaline, and therefore the opposite effect of the sedative occurs in the form of restlessness and insomnia even if the original stimulus for anxiety is resolved. This restlessness and insomnia are called the rebound effects of withdrawing the sedative. After 1 or 2 nights, the neurons will readjust and these rebound effects will cease, but if the sedative is continued to artificially counter the rebound effects, then adaptation will take place and there will be addiction to the sedative. Risk factors. Examples of predisposing risk factors associated with addiction include family history of addiction, burnout, mood disorders, and stress. 5. Homelessness is also a significant risk factor for addiction. 6. Other risk factors identified by the National Institute on Drug Abuse include early aggressive behavior, lack of parental supervision, drug availability, and poverty. 7. Individuals with previous histories of dependence on opiates are at much higher risk for becoming addicted to opioid analgesic. 8. Use of illicit drugs, tobacco, and alcohol is much higher among adults with co-occurring severe psychological disorders. 9. The unique challenges faced by those with co-occurring disorders are discussed in the clinical management section of this concept presentation. Prevalence. The National Survey on Drug Use and Health provides a summary of substance use and mental health for individuals 12 and older in the United States. Alcohol and tobacco use are the most common substances used, while cannabis and misuse of prescription pain medication are the most prevalent illicit substances used in the United States. 10 over 21 million Americans aged 12 and older have substance use disorders, yet only just over 11% receive treatment. 10 The misuse of prescription medication continues to rise and is most prevalent among those who misuse opioid prescription medication. Misuse of prescription medication is understood to be using medication other than has been directed by the prescribing provider, or the use of a prescription written for another individual. 10 In addressing the prevalence of behavioral addictions, there is little research that articulates these data, so the prevalence is not well established. The more commonly recognized behavioral addictions are gambling, shopping, internet use, video games, exercise, food addictions, and several subtypes of sex addiction. 4. Box 351. Symptoms and behaviors of addiction: fatigue, insomnia, headaches, seizure disorder, changes in mood, anorexia, weight loss, vague physical complaints, overabundant use of mouthwash or toiletries, appearing older than stated age, unkempt appearance, leisure activities that involve alcohol and/or other drugs, sexual dysfunction, decreased libido, erectile dysfunction, trauma secondary to falls, auto accidents, fights, or burns, driving while intoxicated, failure of standard doses of sedatives to have a therapeutic effect, financial problems, including those related to spending for substances, frequent reference to alcohol or alcohol use indicating preoccupation with an importance of alcohol in the person's life, problems in areas of life function, modified from Lewis, S.L., Dirksen, S.R., Heitkemper, M.M. et al. Medical surgical nursing, assessment and management of clinical problems. St. Louis, Mosby. Substance abuse among nurses. Substance use among healthcare professionals has been a long-standing concern for all health professions. The American Nurses Association estimates that 10% to 15% of nurses are either recovering from substance use or have impaired practice. 11 states across the country are seeing a marked increase in substance abuse issues among nurses, leading to increasing numbers of nurses facing nursing board intervention. Identifying risk factors for substance abuse among nurses is key if early intervention and prevention are to be achieved. Risk factors specific for nurses include job-related stress and having access to controlled medication. Many nurses experience guilt and shame around their substance use. They often feel that have let patients and colleagues down or may be afraid of how colleagues will view the 11. Assessment. The first priority of nursing assessment for persons experiencing addictions is aimed at identifying those in need of emergency management so they can be referred immediately for stabilization. Non-emergency priorities of the assessment are aimed at identifying possible addictions by interview and screening so that treatment options for recovery can be explored. Screening tools are used during the history and examination. These are discussed under secondary prevention in the clinical management section. History. There are a number of general symptoms an individual with substance use or induced disorders may mention while taking a patient history. The patient history also includes exploring the use of prescription and over-the-counter drugs, herbal and homeopathic products, caffeine, tobacco products, alcohol, and recreational drug use. However, the patient may consider the disclosure of addictions to be risky, so it is important to reassure the patient that the information is confidential. Even so, because of the presence of deception in addictive processes, patients are unlikely to disclose addictions accurately. 12 For this reason, it is recommended that the nurse build trust and rapport by using a therapeutic communication technique called motivational interviewing. The use of motivational interviewing is discussed further because it has been demonstrated to improve recovery significantly. 13 However, it is also recommended that the nurse use motivational interviewing methods during the assessment to identify the following defining characteristics for addiction: tolerance and withdrawal, deception of the self and others, and relapse processes. This interview technique allows the nurse to explore the defining characteristics as they arise without loss of rapport. The following discussion of the defining characteristics of addiction is provided to facilitate the assessment. Tolerance and withdrawal. Tolerance and withdrawal are the result of the neurochemical processes already discussed: habituation and adaptation. The nurse can identify tolerance when the patient acknowledges the need for increasingly more of the stimulus to achieve reward. Withdrawal symptoms occur when sufficient quantities are not obtained to achieve reward because of tolerance or because of reducing consumption. There are two categories of withdrawal symptoms: the stress reaction symptoms and the rebound symptoms. Stress reaction symptoms are mediated by the autonomic nervous system and result from the stress of stopping the addictive behavior. Stress reaction symptoms range from mild uneasiness and irritability to extreme agitation, rapid pulse rate, tremors, and panic. Rebound symptoms occur when adaptive changes in the brain that counter the effects of the addiction continue despite cessation of the addictive substance or behavior. Therefore, the effects of the rebound symptoms are the exact opposite of the effects of the addiction. If the addiction is stimulating, then rebound symptoms will be sedating and manifest as lethargy. If the addiction is sedating, then the rebound symptoms will manifest as agitation. This explains why stimulant addicts experience a crashing of mood and energy as a rebound symptom but also have anxiety as a stress reaction symptom. Agitation will be a rebound symptom to stopping the use of substances that are sedating, such as alcohol or benzodiazepines, and the agitation may be compounded as a reaction to the stress of stopping the substance. Deception of the self and others. Deception of the self and others may be loosely referred to as denial. Sometimes addicts deliberately deceive others to hide their addiction, but they may also deceive themselves. Individuals with substance use disorders may be dishonest, covert, engage in criminal activity, and return away from family and friends in order to maintain their substance use. These individuals may find themselves engaging in activities that they would have never otherwise considered doing in order to maintain their substance use. Deception underlies tension, stress, and betrayal that is experienced among family and friends of individuals who have substance use disorders. Relapse. Relapse processes are invariably linked to addiction, and they are addressed in the clinical management section because they are directly related to recovery. Physical examination. A routine physical exam may disclose evidence of addiction. Long-term use of toxic substances may harm the liver and result in symptoms of liver failure, such as jaundice, fatigue, abdominal discomfort, or ascites. Intravenous drug users may have damaged veins and be at risk for coronary complications that include endocarditis. Opiates and stimulants reduce appetite, so users of these substances tend to develop an undernourished, emaciated appearance. Physical signs typical of a withdrawal stress reaction should be noted, such as anxiety, palpitations, shakiness, increased heart rate, and diaphoresis. Other physical exam findings are listed in Box 351. Diagnostic tests. Diagnostic tests detect the presence of drug and alcohol metabolites in the blood and urine. Tests may also be ordered to detect addiction-related disorders, such as evidence of hepatitis, liver disease, and smoking-related disease. Clinical management. Primary prevention. To prevent addiction, nurses need to understand the individual and social contexts in which addiction occurs. This section examines primary prevention from the community perspective and from the individual perspective. Community health. Successful models for the prevention of addiction promote healthy families and healthy community. 14 examples of large-scale community treatment programs shown to be effective in preventing addiction have been implemented in Australia. 15 in Vancouver, British Columbia. 16 in the United States. The National Institute on Drug Abuse has established recommendations to support research-based community prevention. 7 NIDA suggests that a well-constructed community plan first identifies the specific drug problems in the community and then builds on existing resources to develop short-term goals and projects that include the assessment of outcomes. 7 Numerous examples of educational and community-based programs are offered on the NIDA website. 7. Individual positive coping strategies. Positive coping strategies are nonspecific and highly individualized to the individual, their past experiences, and the specific situations. Ideally, positive coping strategies are used as opposed to turning to drugs or alcohol as a coping strategy. Coping strategies link to general strategies that optimize wellness, including maintaining good health, proper nutrition, and exercise. Additionally, maintaining positive personal relationships, positive social support networks, and maintaining positive self-esteem underlie positive coping strategies. For nurses and other healthcare providers, personal coping strategies include developing a self-care philosophy that includes setting limits at work by saying no to unreasonable expectations, debriefing stress through supportive professional relationships, and developing rituals for coping with loss, grief, and death. It is recommended that all nurses reflect upon and further explore ideas for the positive management of stress so that they can experience long and rewarding careers free from substance use. Secondary prevention. The United States Preventative Services Task Force recommends screening all adults over age 18 for alcohol. Mrs. 17 Some evidence endorses the use of the National Institute on Alcohol Abuse and Alcoholism Quantity and Frequency Questionnaire and the CAGE Questionnaire by Generalist Nurse. 18 Box 352 presents these instruments with recommendations for their use to detect possible addictions by nurses. The CAGE questionnaire is easily adapted for screening of other substances and behavior. 18 Initially developed by Ewing in 1984 to screen for alcohol addiction, the reliability and validity of the CAGE questionnaire have been established. 19 It does not distinguish between past and present problems, but it is an expedient and non-threatening approach to assessing patients for the defining characteristics of any addiction. 18 Collaborative interventions. The clinical management of addictions and consequences of addictions by the generalist practice nurse consists of emergency management measures to stabilize life-threatening complications and non-emergency measures to facilitate the recovery from substance abuse. Emergency management. Generalist practice nurses are likely to encounter many different emergency scenarios related to adverse drug reactions and/or overdose. The primary goal of emergency management is to prevent life-threatening complications that occur as a result of substance consumption or that result as the substance clears the system. 20 Agency-specific protocols should be followed when indicated. Presenting signs and symptoms depend on the doses of substance or substance combinations that may have been taken, and the nurse should institute basic life support measures as needed until toxicology findings are confirmed and resuscitation efforts are directed by advanced practice providers. Many agents impact the respiratory system, and respiratory management includes monitoring and support. Cardiovascular support includes monitoring and support. Box 352. Alcohol screening. NIAAA quantity and frequency questions. 1. On average, how many days per week do you drink alcohol? 2. On a typical day when you drink, how many drinks do you have? 3. What is the maximum number of drinks you had on any given occasion during the last month? CAGE questions. In the last 12 months. 1. Have you ever felt like you should cut down on your drinking? 2. Have people annoyed you by criticizing your drinking? 3. Have you ever felt bad or guilty about your drinking? 4. Have you ever had a drink first thing in the morning to steady your nerves or get rid of a hangover? Screen positive if. A positive response on one or more questions from CAGE and/or consumption. Men greater than 14 drinks/week or 4 drinks/occasion. Women 7 drinks/week or 3 drinks/occasion. Over 65 years old 7 drinks/week or 3 drinks/occasion. From National Institute on Alcohol Abuse and Alcoholism. Helping Patients Who Drink Too Much, A Clinician's Guide. NIH Publication Number 07-3769. Retrieved from Opiate Overdose. There is significant risk of death from respiratory arrest with opiate overdose. Naloxone is a rapid-acting drug that restores respiratory function almost immediately by blocking opiate receptors. Naloxone is frequently used by paramedics, police officers, and even family members as an emergency measure for opioid overdose in the community setting. Nurses and others who administer naloxone should be aware of the potential for injury to both the individual administering the drug and the individual receiving the medication due to the effects associated with this drug. The rapid reversal effect of the opiate is very uncomfortable and can cause fear and panic for the user when consciousness is restored. Acute alcohol withdrawal syndrome. Acute alcohol withdrawal syndrome is a life-threatening condition that may occur unexpectedly whenever long-term, daily alcohol consumption is abruptly discontinued. This may occur in any setting, for example, on admission to the hospital for some other reason. Such patients may deny alcohol use for fear of legal implications or because of shame. Consequently, the nurse may be unprepared for the sudden onset of acute alcohol withdrawal syndrome. When it occurs, the onset of alcohol withdrawal syndrome is highly variable, usually beginning within 6 to 9 hours of the last 20 signs that may lead the nurse to suspect the onset of alcohol withdrawal syndrome are alterations in mental status, tremors, seizures, tachycardia, and hypertension. Late signs such as bradycardia or hypotension are indicative of cardiovascular collapse and the impending need for resuscitation. Other signs of possible alcohol withdrawal syndrome are irritability, depressed mood, impaired concentration, dizziness, hyperreflexia, ataxia, pyrexia, anorexia, and insomnia. 20. Wernicke encephalopathy and Korsakoff syndrome. Wernicke encephalopathy and Korsakoff syndrome are two stages of the same emergency problem. Heavy alcohol use leads to poor nutritional intake and also inhibits B vitamin absorption. This leads to alcohol neuropathy from irreversible brain damage with manifestations of psychosis, ataxia, abnormal eye movements, and death. Therefore, standard treatment for alcohol withdrawal for all patients should also include daily injections of B-complex vitamins. Substance abuse recovery, the non-emergency management of addictions. During substance abuse recovery, the individual struggles to achieve sufficient willpower to maintain long-term sobriety from addiction. The essence of this struggle is known as the relapse process, and an understanding of the relapse process is essential to understanding addiction. For some, addiction recovery may only involve attendance to group support meetings, whereas others may have much more complicated rehabilitation needs. Rehabilitation refers generally to a broad spectrum of treatment options that may be inpatient or outpatient and may include initial detoxification treatment, group therapy, individual therapy, mental health treatment, psychosocial rehabilitation, and others such as comprehensive community support service. 21. The term recovery is used to depict an individual who is sober from an addiction and getting the help needed to maintain sobriety. 22. In successful recovery, craving is recognized as part of the relapse process, and therefore coping strategies are planned in advance to prevent use of the substance or behavior in response to craving. This process is an ongoing struggle as the individual moves through early sobriety from 1 month to 1 year, sustained sobriety from 1 to 5 years, and stable sobriety that begins at approximately 5 years. 22. Figure 352. Recovery and the relapse process. It is a common misunderstanding among many patients and even some clinicians that recovery means simply the absence of addictive behavior, as depicted by line A in Fig. 352. Unfortunately, recovery is complicated by a distinct split between the will for freedom and the will of addiction. Consequently, the recovery from addiction is rarely or never a straight line to freedom, as depicted in line A of Fig. 352. Rather, as soon as anyone suffering from addiction begins to pursue freedom from it, the will of the addiction begins to draw him or her back into it. Therefore, recovery is better demonstrated by lines B and C in Fig. 352 because these lines depict the two opposing forces of will that pull in one direction down toward addiction and in the other direction up toward freedom. It is important for the person in recovery to understand that this process is normal so that his or her self-esteem can withstand any feelings of failure that may result from the inevitable relapse into craving. The idea is that relapse is recognized on the emotional level as craving before use reoccurs, and therefore use can be prevented by implementing the positive coping strategies as planned. Success in doing this enhances self-esteem and strengthens recovery, whereas failure to understand this can damage self-esteem and undermine recovery. Often, it is said that an individual who has been struggling with addiction has entered rehab. What this means is that to a certain extent the individual has overcome his or her resistance to changing an addictive behavior and is now motivated to commit to a treatment recovery program. The overarching goal of any rehabilitation program is to establish and maintain sobriety by helping the patient manage the relapse challenges that will certainly arise. Rehabilitation may also include advanced practice care to manage any mood spectrum problems that emerge as addictive coping subsides. This specialized area of addiction care, which is known as the care for co-occurring disorders or dual diagnosis, is discussed in more detail later. Motivational interviewing. It is well known that in modern healthcare, patient outcomes are greatly influenced by the patient's motivation to change lifestyle behavior. 12. There are hundreds of randomized controlled trials of the motivational interviewing method in healthcare that endorse the simple truth: efforts to persuade patient to change increase their resistance to change. Nurses can be more effective by building therapeutic relationship with the patient and then collaborating with the patient to identify what behavior can be improved or changed. 21. It has been reliably demonstrated that whatever approach is selected in the treatment of addiction, the most significant factor is the motivation of the patient. Motivational interviewing is especially useful in the management of addiction. 23. Motivational interviewing does not involve convincing the patient to do something different. Motivational interviewing focuses on developing a collaborative relationship between the healthcare provider and honors the autonomy of the patient to make informed decisions about his or her behavior. In motivational interviewing, the nurse should listen more than talk. The patient will almost certainly have ambivalent feelings about his or her problem behaviors, and it is important to understand the ambivalence. In particular, the benefits of the addiction should be well understood for any plan of change to be effective. A homeless woman addicted to amphetamines provides a poignant example of the benefits of addiction. In this example, the woman's addiction to amphetamines began when she was sleeping in parks and shelters, where her motivation to use the drugs emerged from a need to stay vigilant at night to avoid being raped, as had happened previously. In addition to the benefit of surviving the night, amphetamines were beneficial in providing her with a temporarily enhanced mood in an otherwise bleak and hopeless setting. Amphetamines provided her with temporary relief from symptoms of rape trauma syndrome. Once the individual's ambivalent situation is understood in this way, the patient and nurse can then collaborate to resolve the motivations underlying the addiction with a personal plan for recovery that anticipates relapse processes. To enhance their abilities to do this, nurses are encouraged to participate in motivational interviewing workshops. As a brief overview, when patients are committed to change, the nurse is able to help them to determine the best course of action, but most patients are not initially interested in change or they are ambivalent about changing. When the patient is not interested in changing, it is recommended that the nurse remain empathetic but raise doubt, provide information with permission, and let the patient know that he or she may return if an interest in change develop. 21. When patients are ambivalent about changing addictive behaviors, the nurse should consider ways to tip the balance toward change without arguing. Arguing with an ambivalent person will put the person in a defensive position in which he or she is resistant to change. One way already discussed to tip the balance toward change is by analyzing the benefits of the addiction so that ideas for meeting the benefits by healthier means can be planned. Another technique is to develop a discrepancy between the patient's current behavior and important goals. There are compassionate, respectful ways to point out discrepancies, and it is important that the nurse is authentic in his or her style of communication. In the example of the homeless woman who is addicted to amphetamines, lecturing her on the harm of amphetamines is likely only to alienate her and make her defensive. As an alternative, the nurse might ask this patient how she would like her life to be in 2 years. Chances are she would like to have a nice home and a job, providing the nurse with a point of leverage because there is a discrepancy between having a nice home and job while addicted to amphetamines. The nurse should determine how motivated the woman is to achieve these goals and perhaps chat about how nice it would be to have her own apartment and a job. Patient motivation can be reported on a scale of 1 to 10. This opens the door to establish a discrepancy between amphetamine addiction and having a nice apartment and job. For example, the nurse might state, "Gosh, it would be really hard to hold down a job and pay rent while supporting an amphetamine addiction, wouldn't it?" Once the discrepancies are established, then resources for relapse prevention and support services can be arranged collaboratively. Pharmacotherapy in substance abuse recovery. Relapse prevention is improved by reducing craving and withdrawal symptoms. This is the aim of pharmacotherapy in Recover. 21. A complete discussion of the full scope of pharmacotherapy in the routine treatment of addictions is beyond the scope of this concept presentation, and there are numerous text sources available for information on the subject. 21. The following is a brief overview to provide the nurse with a framework for deeper research. Methadone medications to treat opiate withdrawal either are substitutes for street opiates or are aimed at reducing the symptoms of withdrawal. 21. Methadone is a long-acting opiate that may be prescribed as a replacement. Methadone can be gradually tapered once the withdrawal is stabilized. Buprenorphine. Buprenorphine may be prescribed rather than methadone. Buprenorphine is a partial opioid agonist and, as such, higher doses can be administered with fewer side effects. 21. Suboxone. Buprenorphine may also be prescribed in a combined preparation with naloxone called Suboxone. Suboxone is taken sublingually, and the addition of the opiate antagonist naloxone in this preparation reduces the potential for abuse of buprenorphine alone by eliminating the opioid euphoria. Clonidine. The antihypertensive clonidine may also be prescribed for symptomatic relief of opiate withdrawal. Nicotine. Nicotine gum and nicotine patches may be prescribed to deliver nicotine into the body during withdrawal from tobacco products. These products are intended to alleviate withdrawal symptoms while tapering the dose of nicotine to 0. There are also nasal sprays and inhalers that serve the same purpose, but they are less popular. 21. Bupropion. Bupropion may also be prescribed for nicotine withdrawal. It is a non-nicotine replacement medication that reduces craving. Naltrexone, nalmefene, and acamprosate. Besides the emergency management for acute alcohol withdrawal, a number of pharmacologic approaches may be taken to facilitate the recovery from alcohol addiction. Naltrexone, nalmefene, and acamprosate are all used to reduce cravings for alcohol. Disulfiram. Disulfiram may be prescribed as aversion therapy for alcohol addiction meant to prevent impulsive drinking. 21. The intent of aversion therapy is to extinguish a negative behavior by pairing it with an unpleasant stimulus. Disulfiram works by disrupting the metabolism of alcohol so that toxic blood levels of alcohol metabolites occur in the bloodstream, causing severe headache, nausea, vomiting, palpitations, flushing, tachycardia, chest pain, and dizziness. Severe reactions that include convulsions and death may also occur, but these are rare. Taking disulfiram usually requires written consent to ensure that the patient is fully informed of the risks and aware that he or she must not consume anything containing alcohol. Therefore, patient teaching is of critical importance. Such food items as vanilla extract and over-the-counter preparations of cough medicine and mouthwash often contain alcohol and are likely to induce the side effects of disulfiram and alcohol incompatibility. No form of alcohol should be consumed for at least 2 weeks after discontinuation of disulfiram. 21. Co-occurring disorders. Also known as dual diagnosis, co-occurring disorders refer to the unique challenges faced by individuals who are chemically dependent and have serious psychological distress. There are 2 broad etiologies of co-occurring disorders. Persons with mental illness may turn to substance abuse to self-medicate the SPD, or the substance use may cause SPD. In either case, motivational interviewing is recommended as part of a comprehensive treatment approach to unravel the motivations that underlie the problem. 24. Safe detoxification from the substances of abuse is usually the first step, but ongoing therapeutic communication skills such as active listening and affirmation will help establish trust so that the etiologies can be understood to avoid years of revolving door treatment for these individuals, sometimes labeled as frequent flyers. By doing so, case management can be established to intervene in the underlying causes of the disorder. For example, there are likely to be logical benefits for the use of illicit drugs and alcohol for individuals with SP24. Street drugs may alleviate symptoms of anxiety and psychosis. Intoxication may facilitate social interactions and mask psychosis as substance-induced. Among the users of street drugs, substance-induced psychosis is socially acceptable, whereas psychosis from being mental is not. An understanding of all the logical reasons not to stop taking street drugs will facilitate the development of treatment plans that are more likely to result in long-term remission by addressing these needs as logical within the patient's social ecology. There are some contraindications for the use of motivational interviewing in dual diagnosis. The patient might be too psychotic to benefit from motivational interviewing. 24. If so, the psychosis will have to be stabilized before motivational interviewing can be of any significant value. These patients may also be too dangerous for motivational interviewing. 24. Dangerousness necessitates the removal of freedom, and this contradicts the principle of autonomy in motivational interviewing. For patients who have a degree of orientation to reality despite their confusion or psychosis, the generalist nurse may modify the motivational interviewing method by frequently paraphrasing what the patient says to help maintain an organized dialogue. Nurses should try to keep motivational change talk very concrete and target compliance with medications and other treatments. To avoid escalating anxiety, nurses should avoid exploring despair and instead explore the patient's motivation for using street drugs. As in the ordinary motivational interviewing method, once the motivation is understood, then discrepancy can be established between the drug use and the patient's goal. 24. Interrelated concepts. Addiction as a concept does not exist in isolation, and there are many other interrelated concepts, depending on the specific context of the patient's situation. 3 common interrelated concepts are stress and coping, family dynamics, and cognition. When coping, family dynamics, or cognition become ineffective, the individuals within these systems are at risk for addiction. Mood and affect also overlaps with a risk for addiction. Nurses will benefit by mentally applying the defining characteristics of addiction to these related concepts in their own analyses. Figure 353. Addiction and interrelated concepts. Box 353. Exemplars of addiction: substance-induced disorders, alcohol-induced disorders, cocaine-induced disorders, heroin-induced disorders, inhalant-induced disorders, marijuana-induced disorders, methamphetamine-induced disorders, opioid-induced disorders, tobacco-induced disorders, substance use disorders, alcohol use disorder, cocaine use disorder, heroin use disorder, inhalant use disorder, marijuana use disorder, methamphetamine use disorders, opioid use disorder, tobacco use disorder, behavioral addictions, food addiction, gambling addiction, gaming addiction, internet addiction, sex addiction, shopping addiction. Access exemplar links in your Giddens ebook. Clinical exemplars. There are numerous exemplars of addiction, representing both substance addictions and behavioral addictions. Some of the most common are presented in box 353. This list is brought to life by the story of a student in an addictions concept class discussion who mentioned that her boyfriend was addicted to pornography. Inspired to change by the harm his addiction was causing their relationship, he drove to a distant city where he discarded his entire pornography collection in a dumpster. Evidently, it became clear to him that he was unable to defeat the will of his addiction without help when he found himself in that same dumpster at 3 a.m. rummaging for remnants of his precious pornography collection. Stories such as this clearly illustrate tolerance, withdrawal, deception, loss of willpower, and relapse, but interrelated concepts are also clear. The boyfriend's will for freedom was motivated by the harm his addiction had on his family dynamics, mood, and cognition, but his coping abilities were not adequate to withstand the will of addiction. The nurse's role in this story is to recognize how these concepts interrelate so that the boyfriend's motivation to cope can be strengthened with a collaborative plan that will vary, depending on the local resources and the individual's sense of what will work for him. Featured exemplars: tobacco use disorder and tobacco withdrawal. Tobacco use is the most common addictive disorder and the leading cause of preventable disease, disability, and death. Nicotine, a stimulant substance found in tobacco, increases arousal and alertness, increases heart rate, blood pressure, and cardiac output, and decreases appetite. Cigarette smoking is the most predominant form of tobacco use. It is estimated that 85% of smokers who try to quit on their own relapse within 1 week because of the withdrawal symptoms that include irritability, craving, depression, anxiety, cognitive and attention deficits, sleep disturbances, and increased appetite. 25. Alcohol intoxication. Alcohol intoxication is one of the most common substance-induced disorders. It occurs when alcohol is ingested faster than the liver can metabolize it. Physiological effects of alcohol intoxication are related to the dose. Euphoria, reduced social inhibitions, and flushed skin are associated with lower levels of alcohol intake. Drowsiness and progressive impairments in balance, coordination, judgment, and erratic or sometimes violent behavior occur with greater levels of alcohol intake. Sufficiently high levels of intake lead to nausea, vomiting, and potentially lethal depression of the central nervous system. Alcohol use disorder. Alcohol use disorder is one of the most prevalent of the substance use disorders. It is estimated that 15 million adults 26 and more than 623,000 adolescents between ages 12 and 17 years had an AUD in 2015. AUD results from long-term excessive alcohol use and is characterized by the inability to cut down or stop drinking, craving, interference with family or job, alcohol tolerance, withdrawal, deception of the self and others, and relapse processes. Opioid use disorder. Opioid use disorder involves the misuse of a wide range of drugs from multiple sources, including prescription pain medications, street drugs, and drugs to treat addictions. Opioids cause central nervous system depression, leading to analgesia, euphoria, drowsiness, relaxation, and detachment from the environment and impaired decision-making. Over 2 million individuals ages 12 and older suffered from substance use disorder of prescription pain medication, 591,000 used heroin. 27. Gambling disorder. Compulsive gambling, a behavioral addiction, involves an uncontrollable urge to gamble despite social consequences. Gambling disorder is characterized by gaining a thrill from gambling risk, preoccupation with gambling, taking increasingly larger gambling risks, and using the behavior as a means to cope with problems, guilt, or depression. Gambling disorder closely resembles substance use disorders in the physiological response but also social consequences, including relationships, economic, and occupational. It is estimated that of the 80% of adults who have gambled, 2% or 3% have experienced a gambling problem, representing more than 1 million individuals with gambling disorder. 28. Case study. Case presentation.